afternoon, and thank you for being with us today. I'm Sister Mary Haddad, President and CEO of the Catholic Health Association. Since their arrival in 1727, Catholic sisters have played a critical role in establishing healthcare in the United States. They founded hospitals to care for poor people, immigrants, and other marginalized communities. That legacy endures today. Catholic hospitals now care for 1 in 7 patients nationwide, many of whom rely on Medicaid. Protecting and strengthening Medicaid is not just sound policy. It's a moral imperative to ensure continued access to care for those who need it most. Each year, Catholic hospitals in the U.S. provide care for approximately 88 million patients, including more than 4.5 million inpatient admissions, 19.5 million emergency room visits, and over 99 million outpatient visits. The Catholic Health Association is the largest network of nonprofit healthcare providers in the U.S., representing more than 600 hospitals, 1,600 long-term care facilities, and countless other health facilities. Together, we serve millions of patients and families across the country, in urban and rural areas, and in communities both affluent and underserved. I'm joined today by Eduardo Conrado, President of Ascension, Eric Wexler, President and CEO of Providence, Mike Slabowski, President and CEO of Trinity Health, and Joe Hodges, Lead Regional Executive at SSM Health. Collectively, these systems represent 39 of our 50 states, and you'll hear from them shortly. CHA is deeply concerned about the current proposals in the House to overhaul Medicaid. These proposed changes threaten access to care for millions of Americans, particularly those in underserved areas where our member systems work every day to provide quality, compassionate care. Among the most troubling aspects of the legislation are changes to work reporting requirements, provider tax policy, state-directed payments, and retroactive coverage provisions. These provisions could result in coverage losses for millions of people, creating new administrative barriers for families, providers, and states, instead of strengthening our healthcare system. Congress has a moral obligation to consider the real and harmful consequences these proposals would have on our nation's healthcare safety net and the impact on the lives of America's most vulnerable individuals. Medicaid is not just a health program, it's a lifeline. It provides access to care for those in our nation who need it most: poor and vulnerable children, pregnant women, the elderly, adults, and disabled individuals, while ensuring their dignity. Congress should not take America down a dangerous path of drastically reducing access to health care in the United States. At CHA, we firmly believe that health care is a fundamental human right, essential to human dignity and flourishing. We urge Congress to reconsider these proposals and instead champion policies rooted in compassion and dignity by ensuring everyone has access to affordable health care coverage. By protecting our most vulnerable, we create a healthier, stronger society for everyone. I would now like to introduce Eric Wexler, President and CEO of Providence. Eric?
Well, thank you, Sister Mary Haddad, and thanks to all who are participating today. We are at an inflection point in the provision of healthcare to this country, not just to the vulnerable, and facing what we call a poly-crisis. And that crisis includes inflation, labor shortage, tariffs, but most impactfully, what is being proposed in Congress right now to cut Medicaid. And as Sister Mary Haddad said, this is not about people that just aren't of means. This is about 50% of the children in the United States who are born and needing Medicaid coverage. It is about the disabled. It is also about veterans. Medicaid is not a welfare program. And at Providence, where we serve in 7 states and have a significant impact on the communities we serve, 30% of our support for our communities are for people that are on Medicaid. When Medicaid suffers, the entire country suffers because people that are dependent on having access for preventative care need this type of coverage so that they don't get sicker and wind up in our emergency departments and in our ICUs. So, for potential short-term gain, uh, just a little longer in that short term, we will have long-term pain. And all of healthcare will be affected by that. Now, coming out of the pandemic, we were destabilized by what occurred, but this polycrisis that we face right now will potentially destabilize the health system in the future, and all of us will be severely impacted by that. With that, I'll turn it back over to you, Sister Mary, and thank you for the opportunity to allow Providence to speak at this important conference.
Thank you so very much, Eric. Next, we'll hear from Eduardo Conrado, President of Ascension. Eduardo?
Thanks, Sister Mary. Thanks, Eric, for your comments. Good morning, everybody. I'm Eduardo, President of Ascension, as Sister Mary mentioned. Just to put it in context, Ascension is one of the leading nonprofit Catholic healthcare systems in the U.S. We serve communities in 16 states plus Washington, D.C. We have 99,000 associates and 23,000 providers dedicated to caring to others every day. As Sister Mary mentioned, our mission is to deliver compassionate, personalized care to all, with special attention to those who are most in need. That includes the working class and the poor, who have far too often been left behind by the economy and by Washington. Just to put it in context, 20% of our patients are covered by Medicaid or are uninsured. Ascension in 2024 served 6.1 million unique lives. Nearly 750,000 of those lives were covered by Medicaid. 350,000 of those lives were either uninsured or self-paid. Of the roughly 75,000 babies that Ascension delivers annually, 41% were insured by Medicaid. Hospitals like Ascension, Providence, Trinity Health, and OSEF cover nearly 34% of the costs for Medicaid patients. Now, if you flip that for the uninsured or underinsured, we absorb roughly 88% of the costs to deliver care for those lives. Now, for them and for many others, access to healthcare depends on decisions being made right now in Washington. That is why I'm here today, to urge Congress to recognize the proposed changes to Medicaid and the ACA marketplace included in the current budget package. These cuts will harm real people. They will reduce access to care, especially for those already facing barriers in many states. Let me be clear, Ascension supports the effort to remove fraud, waste, abuse in public programs, but this proposal does not do that. Now, instead, as Sister Mary Haddad mentioned, it creates unnecessary red tape, which causes eligible people to lose coverage because of paperwork problems and system errors. Medicaid is not a handout, it's a safety net. It ensures that children, seniors, low-income families, and people with disabilities get basic health care. These are not just policy issues, but they're personal, that involves people or neighbors. Recently, a young boy in Texas came into one of our facilities with severe symptoms. Medicaid covered the test that found a brain tumor, and he was able to receive life-saving care that put him on the road to recovery. That's what's at stake. Real people, real families, real outcomes, and we cannot have that taken away. Adding work requirements is not just a policy change. It's a shift away from the purpose of the program. We also cannot forget rural communities, as Sister Mary mentioned, where hospitals are already closing and where Medicaid patients often make up the majority of the patient population. Cuts at this scale would deepen financial pressure on hospitals, shift even more burden into the private sector, and limit access for everyone, not just those covered by Medicaid. Eric did a very nice job explaining the current environment in the healthcare sector in the US. These changes would have serious consequences. Cutting critical services, make it harder to hire and keep caregivers, risk hospital closures, and limit states' ability to fund Medicare through proven tools like provider tax. We're asking Congress to reconsider. We can improve Medicaid in ways that protect dignity and strengthen care, but red tape, caps, and funding cuts are not the answer. We must do better for the families we serve, for the caregivers we support, and for the future of Catholic and nonprofit healthcare in the country. Sister Mary, I'll hand it back over to you. Thank you.
Thank you. Thank you to that. Amen to that, Eduardo. Now I'd like to turn it over to Mike Slabowski, President and CEO of Trinity Health. Mike?
Well, thank you, Sister. So, let's be clear. We can't cut hundreds of billions from Medicaid without hurting people and weakening our communities. We've seen it firsthand. When people lose coverage, they skip checkups, they stop taking medications, and eventually show up in the ER sicker and in need of more costly care that could have been prevented. And that's not just bad for health, it strains hospitals, overcrowds our emergency rooms, drives up cost for everyone, insured or not. Medicaid cuts don't just impact those who rely on it. The ripple effect, it will impact everyone, and protecting access to care is how we protect the health of and future of our communities. So by way of background, Trinity Health, we're a not-for-profit national Catholic system, and our 127,000 colleagues and caregivers serve in 26 states. Our 93 hospitals, our physician groups, home care agencies, community health and well-being programs, and senior care facilities serve the full range and types of communities across the country, including rural, suburban, and urban safety net communities. We're really a microcosm of the entire country. We provide services to families, women and children, seniors, nursing home residents, military veterans, and adults with disabilities. And we also operate one of the largest programs for all-inclusive care for the elderly called PACE, which includes those dually insured with Medicare and Medicaid coverage, and through outpatient daycare centers enables seniors to continue to live at home versus in nursing homes and other long-term care facilities. Medicaid, as Eduardo said, it's the coverage for at least 20% of those we serve on average, with some of our communities exceeding 25% of our patients. And for our nursing homes and long-term care facilities, it is far the predominant form of coverage. These community members would not have access to health coverage but for Medicaid. And even at the current coverage and funding levels, Medicaid payments are below our cost of delivering care to these members by well over $500 million a year, let alone any additional reductions contemplated by Congress. Our estimates suggest that we're at risk of operating losses exceeding $1 billion per year if a significant number of those we serve lose their healthcare coverage, combined with the proposed reductions in Medicaid payments. With reductions in eligibility, more patients will be completely uninsured. The Congressional Budget Office estimates a minimum of 7.6 million people who will become uninsured if the bill becomes law. Employers who provide health coverage to their employees realize that their healthcare costs are high because they, in effect, subsidize shortfalls that providers incur serving Medicaid and Medicare patients. So further cuts to Medicaid funding will create more economic chaos because employers will not accept additional burdens for a government responsibility. We've heard statements about able-bodied adults who should be working and not taking advantage of Medicaid. Our trained financial counselors help patients every day who are eligible to obtain Medicaid coverage under strict state and federal guidelines. And we can say with confidence that we do not see the waste, fraud, and abuse of the program that's been stated. We also know from experience that states that have attempted to impose work requirements have spent more managing that initiative than they have spent providing Medicaid coverage to those who need it. While not perfect, Medicaid's a medical and social safety net that's a fundamental responsibility of government to serve communities. At Trinity Health, we seek to find opportunities to work with federal and state governments to have providers like us assume responsibility for total cost of care and outcomes for populations instead of channeling funds through middlemen. Our PACE program that I described earlier is an example where we've been able to manage the care for seniors with better outcomes at a lower cost. So we implore our legislators to pursue innovative ways other than simply cutting funding or eligibility to serve those most vulnerable. Thank you, and back to you, Sister Mary.
Thank you so much, Mike. And lastly, we'll hear from Joe Hodges, the lead regional executive at SSM Health. Joe?
Thank you, Sister Mary. And thank you for this opportunity to participate in the advocacy for the most poor and vulnerable in the communities throughout our nation. This is really important work that we are doing every day, and I am honored to be here today. In terms of SSM Health, I am in charge of operations for the 4 states, which includes Wisconsin, Illinois, Missouri, and Oklahoma. Oklahoma is near and dear to my heart. I'm a native Oklahoman, and I grew up in a rural part of Oklahoma, about 3.5 hours northwest of Oklahoma City. It's called the Panhandle of Oklahoma, and many of you all know where the Panhandle of Oklahoma is. It's where the Dust Bowl was, and that is where my family was during the Dust Bowl. My mom still lives there, and she still accesses care to one of the hospitals in that county. It's called Beaver County Memorial Hospital. Many years ago, my mom asked me what we were doing at SSM Health to help rural hospitals. And at that time frame, we were not doing a lot. Then we started learning about rural health and realized that many rural hospitals are on the margins. And it's very challenging and different dynamic than maybe in some of the urban areas. So at the time, we began to partner with 16 rural hospitals in Oklahoma. With that, we eventually are now managing 7 of those rural hospitals. The one hospital where my mom lives was the hospital where I was born, Beaver County Memorial. Beaver County Memorial serves the vulnerable population in that county. They are about 45 to 50 miles from any of the nearest other hospitals, which is another critical access hospital. They have very limited amount of providers that are out there, but they provide needed emergency services, from ambulance services to emergency services and things that my mom certainly needs every day, as well as her friends. I am honored to be helping Beaver County Memorial Hospital, but they are just like the other 70% of hospitals in Oklahoma. They have a negative operating margin. That's right, 70% of hospitals in Oklahoma have a negative operating margin. That is very similar to the 87% in Kansas and 70% and 76% in the state of Washington. It is a crisis in rural healthcare. Any challenges that are associated with taking away access or funding to rural hospitals will make them even more vulnerable. That is why it is really important for us to advocate for rural healthcare as well as urban healthcare. I think that's part of why I'm here today and why I'm so passionate about this particular work that we do every day. Let me give you some other statistics about rural healthcare. Rural healthcare carries the largest share of chronic disease burden in our nation. 30 percentile points for obesity and 20 percentile points for premature death. And they also have 25% of all the veterans in the United States live in rural communities. All these people matter. They all need to have access to care, and it is our responsibility to advocate for them. And that is why we're here today. Thank you for this opportunity, and I turn this back to you, Sister Mary.
Thank you so much, Joe. And thank you to Eduardo and Eric and Mike for sharing how these potential cuts would impact your communities. Medicaid cuts will have real implications for hospitals, patients, and the communities we serve. We will continue to work with House Republicans and all federal lawmakers to ensure our health safety net remains intact so that our health systems can contribute to provide vital care to American patients and families. So now we're going to open it up for questions.
Thank you, Sister Mary. To ask a question, please type it into the chat box and include the name of your outlet. We will start with a question from the AP. Republicans have noted that Medicaid enrollment and spending has ballooned in recent years and that these cuts will protect the solvency of the program in the long run. How can costs be brought down without making cuts to the program, or should taxpayers be expected to absorb these costs?
So I guess I would start. I had made the comment earlier that as health systems that provide the full continuum of care, we are very willing to address and take on more alternative payment models in which we can assume total cost of care and outcomes for populations. We've been able to prove through all the Medicare demonstration projects, through our participation in our owned Medicare Advantage programs, and in several Medicaid programs that we've participated in, that we can improve outcomes at a lower cost if providers are given that responsibility instead of working through middlemen like commercial insurance companies that first want to earn their margin and then really they're very adept at denying claims, frankly, of needed care that we provide to people. So I know I'm united with all of the partners on this call today about our interest in support of alternatives to the current way that healthcare is financed.
I'll just add to that. I think Mike's comments were excellent. But in addition, you won't find a provider leader at this meeting today that isn't doing its part to reduce costs within its own health system. We have reduced an enormous amount of discretionary spend, which when it was spent seemed like the right thing to do, but it's just not an option any longer. And as well, we have reduced our FTEs significantly, and we are facing further labor reductions if these cuts go through. The concern that I think we have is when those cuts happen and those FTEs are reduced, it resets healthcare in a way that affects the entire population. And that's why I made that point earlier, that Medicaid cuts may seem like it affects just a portion of those that we serve. But if we end up closing programs and services because the affordability of maintaining them diminishes, then those of us that aren't on Medicaid, that have other forms of access to care, will not be able to have access to that care because those programs will no longer be there. And that's why we've got to focus on this is an ecosystem that must be maintained and not look at it in a partitioned way.
Thank you. Next question comes from Fierce Healthcare. Can you clarify the financial impact Medicaid cuts would have on hospitals? How will they drive up costs, and what's the implication of shifting the burden to the private sector?
I'll take that one, Sister Mary. I think Joe did a nice job talking about the number of rural healthcare hospitals in Oklahoma and in Kansas that are having negative margins. I think those percentages kind of repeat themselves across every state that we're in. If we reduce Medicaid enrollment, it just shifts that population to underinsured and uninsured status, which, as we mentioned earlier, we take care of everybody in our community, which shifts the financial burden into the nonprofits, which in many cases, we cover 85 to 90% of that cost. So all this happening is a shift from Medicaid enrollment to uninsured. Uninsured enrollment will shift the financial burden to the nonprofit systems that are already under pressure in many of our rural and inner city communities.
Specifically to Providence, we see the impact for what's being proposed in the close to $1 billion range on a net revenue base of $30 billion. And so, that is a fairly catastrophic cut in a place where we are already not profitable. We've been clawing our way back since the pandemic occurred. While we've made progress, we still have negative margins, and this will further create the pressures that potentially, as I mentioned earlier, will result in programmatic cuts.
And
So,
in my comments, I had also mentioned $1 billion impact, and also the fact that we currently underwrite Medicaid to the tune of $500 million. So it's an additive feedback. Joe, I'm sorry, I cut you off.
no, my point is that we have to cost shift. If we have less reimbursement, less paying patients that are coming through our doors, we have to then cost shift that over to commercial insurance, where we would have to negotiate and raise the prices for those rates. That in turn gets pushed back down to employers. So it just moves from one bucket to another bucket. And so I think that that's one of the challenges that we have, whether it's a 13 million people lose their health care, or 8 million people, or 10 million people lose their health care. It all shifts around, and we have to be able to shift that around in order to continue with our mission and providing services to all people that walk through our doors. Because everyone who walks through our doors, we are going to take care of them, no matter their payer, no matter where they're from. Those things are irrelevant to us. When people need us, we are there. That's why we're in Catholic healthcare.
The next question is from Bloomberg Government. Along with this webinar, do you all have plans to contact lawmakers or otherwise advocate on these issues in the next 24 to 48 hours as this bill heads to the House Rules Committee tonight?
You bet. It's going on big time right now with our advocacy teams, and we're on call to support any of those efforts.
We've been doing this since January.
Yeah.
One of the first places I visited at the start of the year was Washington, D.C., and met with well over a dozen congresspeople and talked about the impact on their own communities. With one congressperson, 70% of his community is on Medicaid. And so he has a fiduciary responsibility, as lawmakers do, to those that they serve, to ensure that they get what they continue to need to live a good, healthy life. And we're doing that in the best way we can today. We need Congress to stand by our sides and help to continue to make that happen.
Yeah, I would say, in addition to what our individual systems are doing relative to advocacy, that CHA has organized collective fly-in days, and we had one in March that was well represented across the country. And I thought it was interesting, when we were on the Hill, we actually ran into some of our colleagues from Catholic Charities USA. The recognition that this is just not a healthcare issue, this is a social service issue, because they're recognizing the impact it's going to have on that population, which will increase their need for additional services to provide for those who won't have access to the services they need.
The next question comes from Becker's Hospital Review. Given the proposed Medicaid cuts under consideration by the current administration, including work requirements, limits on provider tax funding, coverage restrictions, shorter ACA open enrollment window, etc., what are your top priorities when it comes to advocacy? And what do you hope to achieve with your advocacy? And what do you think is realistic when it comes to the final healthcare package?
Well, those all add up to the $1 billion that Eric and I both mentioned. So, the reality is all of those are a priority to us to be able to maintain the services that we provide to those that are covered by Medicaid. So I wouldn't pick out any one of those items over another, because they all add up to the same situation of impeding access to care and people who will not have coverage, who show up at our doors, and we have to care for them.
Yeah, I would add that over the past 50 years, we have created patches to the reimbursement system, especially, at the federal and state side, so that we could continue to maintain services. So when you affect one of these pieces that at another point in time seem to make sense, it impacts the other. And that's why I think, the leaders that are here are trying to ensure that people understand that this is an ecosystem. So when you make a cut, it does wind up impacting a number of people and potentially others who are in Medicaid as a whole to the access that they need. And as I keep on saying, to everybody in America who might see programs and services close as a result of this, due to the billions of dollars of reduction in reimbursement to health systems like ours.
I would also add to where Mike started in terms of just rethinking the payment model. At the end of the day, we want to keep our populations healthier at a lower cost. In order to do that, I think there's a direct relationship between the government and providers like us, nonprofit, to be able to kind of incentivize keeping the population healthy out of the emergency rooms, which is high cost, providing the appropriate RX or pharmaceuticals if they got a chronic condition, and do medication adherence to be able to kind of, again, keep them out of the high cost side of care on it. So I think the discussion beyond the cuts that are happening now is how do we rethink population health, payment models, and then partnership between nonprofits and government.
The next question comes from Inside Health Policy. With hospitals already so strained financially, how is maternal and children's health currently impacted, and what could happen to your patients if Congress's Medicaid cuts are passed?
Well, it's already happening. I mean, it's really affecting rural communities. We've had to make some painful decisions at a few of our rural hospitals about discontinuing OB services. And as you can imagine, the community reaction is very negative. Legislators' reaction is very negative. The reality is trying to recruit physicians and nurses to rural communities is a challenge as it is, let alone, losing funding for a program like Medicaid. And, we're finding that in almost every market where we believe we have the imperative to try to either consolidate or develop alternatives for women and children's services, that there's tremendous pushback for good reason from those communities and others, and we need help on the solutions.
In terms of statistics, 293 rural hospitals stopped providing OB services between 2011 and 2023. This will continue. There are parts of rural Oklahoma that it will take you almost 3 hours to get to the nearest hospital that will provide OB services. So the impact that has upon families, upon children, is significant. And so this will continue to affect the OB services, but not just OB, but it could be other services as well.
Question from America Media. Any evidence that bipartisan pushback against cuts in Medicaid can be anticipated?
I mean, we certainly hope so. I mean, all of the legislators, regardless of which side of the aisle you're on, have a lot of constituents that are in Medicaid. We talked about it. I mean, it's one out of every 5 Americans got coverage in Medicaid. And then when you combine that with Medicare, another, federal and public program, this is an enormous part of their constituencies.
Final question. Another aspect of the GOP budget plan is to end the enhanced premium tax credits for people who are using the health insurance exchanges. This is projected to push even more people off the insurance rolls. How will we deal with that?
Well, that's the double whammy here because, the impetus has been to try to get people off Medicaid, but have them purchase products on the exchange at discounted prices. Well, if Medicaid goes away and the exchange options go away, people are going to be uncovered. I mean, it's just, it's pretty devastating when you think about the big picture here.
That was the last question, Sister Mary.
All right, thank you so much, Marie. And thank you again to Joe and Eric and Eduardo and Mike for being with us today and really giving light to the devastation that this could have in the communities we serve. And thank you all for joining us for this briefing.